Hi guys, good evening, good evening. Can you all hear me? Can you all see me? Quick feedback. Can you all hear me? Can you all see me? Quick feedback. Okay, can we start? Right. So today we'll be talking about all the important questions that were asked from breast, thyroid, and trauma. So our agenda would be to complete all the important ones. So yesterday's notes have not been uploaded yet. It's been uploaded on the Telegram, I guess. I'll just repin it again, bhai. Okay. Okay. So right. So what are the topics or the questions? So I will start with the thyroid first, and then we'll basically based on this. So the question that was asked on thyroid from a surgery standpoint, they've asked you to write what is a solitary thyroid nodule. They asked you about the solitary thyroid nodule, about thyrotoxicosis, about the thyrotoxicosis. They've asked you about goiter as well as the retrosternal goiter. So these were the questions which were asked in our previous exam. In one of the exams, like if you look at the previous section, solitary thyroid nodule was a 5 marks question, thyrotoxicosis was a 5 marks question, goiter they've asked you 3 marks, retrosternal goiter they've asked you about 5 marks question. And then they've asked you these three put together, solitary thyroid nodule, thyrotoxicosis, and goiter put together as a 10 marks question, right? So there are different questions and different topics that are asked you. We try to club it together as one so that we understand better. So we'll start with the first topic, that is going to be our retrosternal goiter. That is going to be our retrosternal goiter. Okay. Right. So let's start, or we'll start with solitary thyroid nodule. Okay. So the first topic is going to be to write a short note on a solitary thyroid nodule. So we'll write a short note on a solitary thyroid nodule per se. So this is going to be our answer, and this is about the solitary thyroid nodule. Right. So when you write this answer, first of all, you should know that what is a solitary thyroid nodule and what is its components. So the first thing is, whenever you talk about the thyroid swelling, just write a small classification of the thyroid swelling. Now, in the thyroid swelling, you have a diffuse and a localized thyroid swellings. So divide them into two. They have a diffuse and discrete, which is called as localized thyroid swelling. Diffuse thyroid swelling, the answer or the examples are going to be like goiter. It is going to be goiter. In localized thyroid swellings, when I talk about the localized thyroid swellings, the localized thyroid swellings are divided into two categories. One, it is what we call it as the solitary thyroid nodule. It is the solitary thyroid nodule. Another one is going to be a dominant thyroid nodule. Another one is your dominant thyroid nodule, right? So you have two components. One is going to be a diffuse thyroid swelling. Another one is going to be a localized thyroid swelling. Diffuse, the example is going to be goiter. Localized, it is divided into two categories, solitary thyroid nodule and the dominant thyroid nodule. Now they'll ask you, what exactly do you mean by diffuse thyroid swelling, that is goiter? Goiter is described as a generalized, this is described as a generalized enlargement. There's a generalized enlargement of the thyroid gland. So you will see the entire gland is going to get enlarged. If there is a generalized enlargement of the thyroid gland, that is what we call it as goiter. Now, what is a solitary thyroid nodule? Solitary thyroid nodule is actually an isolated single nodule that is going to be present. So how do you look at it? Solitary thyroid nodule, for the best description, you will say that in the solitary thyroid nodule, if you take this as the representation of the thyroid gland, on the either side you have lobes. If a nodule arises from one of the particular site, and this is what we call it as solitary thyroid nodule. Now, what is a dominant thyroid nodule? In a dominant thyroid nodule, it is like a multinodular status, but here one nodule is going to be quite large. So this is a very big nodule that you will see, and there are multiple smaller nodules also. Now, but these small nodules are not as large or evident as the other one. So hence, the one which is going to be quite big is given the name as a dominant thyroid nodule. This is what we call it as a dominant thyroid nodule. So to be very honest, dominant thyroid nodule is actually a multinodular status, and this is what we call it as an ST, and that is a solitary thyroid nodule presentation, or a solitary thyroid nodule. Remember, of your localized thyroid swellings, 70% of them is going to be a solitary thyroid nodule, and 30% of them is going to be a dominant thyroid nodule, right? So you have a 70% is going to be of a solitary variant, and 30% of them is going to be a dominant thyroid variant, right? Now, again, when you go into the clinical features, you should be able to differentiate the clinical features of the solitary thyroid nodules as well as goiter. So talk about the clinical features of solitary thyroid nodule. Clinical features of the solitary thyroid nodule. Now, when you talk about the clinical features of the solitary thyroid nodule, let's put them into perspective. Number one, you will always start with the age of presentation. STNs are usually seen in the 3rd decade of life. It is usually more common in females. It is more common in females when compared to males. This will be more common in females when compared to males, right? Now, how would they present to you, and what are the presenting feature? Now, the presenting complaint is going to be present to you as a localized, it is going to be associated with localized thyroid swelling. Now, majority of these localized thyroid swellings, they are going to be painless. They're going to be painless, and they gradually increase in size. Right? Now, if there is a rapid increase in size, it can be presented as malignancy. If they're gradually increasing in size, it indicates probably it is a benign lesion. If there is rapidly increasing in size, a solitary thyroid nodule which is having a rapidly increasing in size, then it could be a malignant lesion. So patient is going to have a localized thyroid swelling which is going to remain painless and gradually increases in size. Now, obviously, this is the presenting symptoms. Now, any patient who comes to you with the thyroid swelling, obviously you will take for examination. So next heading is going to be on examination. So majority of the times, based upon the findings, you will be able to draw some conclusion. Number one, you will notice that this swelling is going to move upwards with deglutination. This is going to move upwards with deglutination. As we all know, every single thyroid swelling is going to move upwards with deglutination because it is attachment of its Berry's ligament. That is, the thyroid gland pulse is attached to the pretracheal fascia with the Berry's ligament. Every time the patient swallows, the trachea moves upwards, the Berry's ligament pulls upwards. Pulling of the Berry's ligament will also cause pulling of this nodule up. So this is going to move upwards with deglutination. Now, along with that, when you're going to palpate it, you will usually be addressed with surface. So when you look at the surface of the thyroid nodule, it can be smooth or it could be nodular. Smooth probably indicates a benign lesion. Nodular probably indicates it is going to be a malignant lesion. Right? Now, along with the surface, you look for other components. It is going to move upwards with deglutination. The surface is going to be either smooth or nodular, and it is usually not fixed. It is usually not fixed, right? Now, if you say what are the other features that you can talk about? So other features that you will encounter here. Now, the patient of solitary thyroid nodule. So we call it as the solid features associated with ST, and that is a solitary thyroid nodule. It could be associated with that of hypothyroidism. It could be associated with hypothyroidism. It could be associated with euthyroid status, or it could be a hyperthyroid status. So patient can have signs and symptoms of hyperthyroidism also. If it is a hypothyroid associated component, if it is a hypothyroid or else euthyroid associated component, in these conditions I can say it is probably a benign lesion. It is probably a benign lesion, right? Or it could also be associated with a malignant lesion, because the malignant lesions are usually euthyroid. But if it is a hyperthyroid state, it is what we call it as solitary thyroid nodule causing toxicosis. So it is called, it could be probably toxic adenoma. It could be probably toxic adenoma. So in thyrotoxicosis, again, I'll discuss in detail. So when you talk about if a patient is having features of hyperthyroidism, this is toxic adenoma, right? So this you have to mention in other features so that your examiner knows that you also know the differential diagnosis for this. So any patient who is present with solitary thyroid nodule-like presentation, I would like to evaluate it. So the next one is going to be investigation. Now here is an important thing, that whenever you're talking about any patient who has a thyroid swelling, the list of investigation or the sequence is going to be quite simple to remember. Every patient should undergo a thyroid function test. Now in the TFT, I'm going to measure the T3 level, the T4 level, as well as the TSH level. Now because based upon this, I know whether I'm dealing with hypo, U or hyperthyroid. Remember, a hyperthyroid swelling can never be malignant, so there is no role of FNSE if the patient is having a hyperthyroid status. So first one is going to be thyroid function test. Second one is going to be ultrasound to see whether it is nodular or smooth. And third one, to determine, you have to go with cytology, which is going to be FNSE. You have to follow these three protocols. Get a thyroid function test, get an ultrasound of the thyroid gland, as well as the FNSE of the STN that is present, right? Now, you should always mention that once you have FNSE as a note point, you have to write it. Should be done. It should be done if swelling is associated with euthyroid status or hypothyroid status. Euthyroid status or the hypothyroid status. Remember, there is no role of FNSE if the patient is having hyperthyroid. Why? Because normally the tumor that is going to be formed, that a malignant tumor or a malignancy that is going to develop in the thyroid gland, is usually not associated with functional status of the gland, so it cannot secrete the hormone. So normally we say malignant swellings are likely to be U or hypothyroid. They are not going to produce functional cells. Because they do not produce functional cells, they cannot increase the hormone secretion, so they will never be hyperthyroid. Okay? Now to get into the component, how would you like to manage? So it all depends upon what report did you get on FNSE. So the management of solitary thyroid nodule. So this is going to be the management of the solitary thyroid nodule. It is based on the FNSE finding. It is based on FNSE finding. So what finding are we going to get on FNSE? Based on this, we are going to decide that what is going to be the management protocol like, right? Now, so any patient, I'll just write an algorithm. Remember, any patient who has gotten a solitary thyroid nodule, you will take the patient for FNSE, stands for fine needle aspiration cytology. This is also expected for you in the exam to write the full form. It is your fine needle. It is going to be the fine needle aspiration cytology. FNAC stands for fine needle aspiration cytology. That is the basic that is expected out of it, right? Now, whenever you do an FNAC, based upon the FNAC, you will encounter certain findings, right? So let's look at those findings and try to evaluate them, right? So you will get an FNAC done. Based upon the FNAC, what are the findings? And based upon those findings, you are going to tailor your management also. Now, this starts with the first possibility that you can have. Now, let's say you have done an FNAC and you got a non-diagnostic aspirate. You got a non-diagnostic aspirate. That means FNAC was done, the report was inconclusive. What are you going to do? Remember, management for such conditions, it is going to be repeat. It is going to be repeat FNAC under USG guidance. Repeat FNAC under USG guidance. Now, when you do an FNAC under USG guidance, you will get a better yield for the report. Now, on the other hand, what is the second possibility that you can have? The second possibility is you can get a benign lesion. So the FNAC confirms that it is a benign lesion. In a benign lesion, I have to see whether we are talking about a cystic or a solid nodule. Whether it is a cystic nodule or whether it is a solid nodule. Now, if it is a cystic nodule, the current recommendation is going to be USG guided aspiration. It is going to be USG guided aspiration. If it is a benign or solid nodule, then it is only going to be observation. I am not going to do any active intervention. I am not going to do any active intervention if it is a solid nodule. Now, the third possibility that you can see here, it is going to be something called as AUS. AUS stands for atypia of unknown significance. It stands for atypia of unknown significance. It stands for atypia of unknown significance. Whenever you have atypia of unknown significance, here the answer for the management, it is to repeat FNAC. This is to repeat fine needle. निशा कौशिक कुछ समझ नहीं आ रहा बेटा, आज का टॉपिक है, हम बात कर रहे हैं सॉलिटरी थायराइड नोड्यूल पे अगर सवाल आएगा तो जब भी सॉलिटरी थायराइड नोड्यूल पे सवाल आएगा तो सबसे पहले आपको बताना है कि थायराइड स्वेलिंग जो है ना वो क्लासिफाई कर सकते हो इनटू टू कैटेगरीज. दो डिफरेंट टाइप्स के आपके स्वेलिंग्स होते हैं थायराइड के. एक आप बोलते हो कि डिफ्यूज थायराइड स्वेलिंग है, दूसरा बोलते हैं लोकलाइज थायराइड स्वेलिंग है. डिफ्यूज का मतलब क्या है कि जहां पूरा ग्लैंड एनलार्ज हो जाता है. कहने का मतलब ये है कि मान लीजिए ये आपका नॉर्मल साइज ऑफ द थायराइड ग्लैंड है. डिफ्यूज में आप देखोगे कि पूरा ग्लैंड ही एनलार्ज हो जाएगा. ठीक है, पूरा ग्लैंड ही एनलार्ज हो जाएगा. इसको आप बोलते हो डिफ्यूज थायराइड स्वेलिंग और इसका जो क्लासिकल एग्जाम्पल है वो गॉइटर है. फिर आप बोलोगे कि लोकलाइज. लोकलाइज का मतलब किसी एक जगह पे पूरा ग्लैंड एनलार्ज नहीं होता. लोकलाइज को हम डिवाइड करते हैं दो डिफरेंट कैटेगरी में. एक को आप सॉलिटरी बोलोगे, दूसरे को डोमिनेंट बोलोगे. सॉलिटरी का मतलब है कि आप देखोगे कहीं एक जगह पे ग्लैंड पे एक नोड्यूल बना हुआ है, उसको आप बोलते हो सॉलिटरी का मतलब सिंगल थायराइड नोड्यूल बना हुआ है. फिर एक और है डोमिनेंट थायराइड डोमिनेंट. डोमिनेंट का मतलब क्या, ये भी लोकलाइज्ड है, एक ही जगह पे, पूरे ग्लैंड में नहीं, एक ही जगह पे. बट आपको यहाँ क्या देखने को मिल रहा है कि आप देख रहे हो कि एक जो नोड्यूल है वो बहुत बड़ा है व्हेन कंपेयर टू रेस्ट ऑफ देम, इसलिए इसका नाम पड़ा डोमिनेंट. मेजॉरिटी ऑफ द टाइम्स व्हेन यू सी दिस आपको देखोगे कि सॉलिटरी हमारा बहुत कॉमन होता है. 70% जो आपके लोकलाइज थायराइड स्वेलिंग्स होते हैं वो आपके सॉलिटरी होते हैं, 30% डोमिनेंट होते हैं. तो ये आपका पहला पार्ट हो गया. फिर आप बोलोगे कोई भी पेशेंट अगर सॉलिटरी थायराइड नोड्यूल मतलब एक लोकलाइज थायराइड स्वेलिंग के साथ है, वो प्रेजेंट कैसे करेगा, उसकी प्रेजेंटेशन क्या है. नॉर्मली ये आपको देखने को मिलेगा 30 से 40 में, दैट इज 30 to 40 ईयर्स. फिर आप बोलोगे ये ज्यादा फीमेल्स में देखने को मिलता है. प्रेजेंटेशन क्या है, एक नोड्यूल मिलेगा, स्वेलिंग है, यूजुअली उसमें कोई दर्द होता नहीं है, पेनलेस होता है, वो धीरे धीरे बढ़ता है. तो अगर वो बिनाइंग हो जाएगा, अगर वो जल्दी बढ़ने रैपिडली इंक्रीज होगा तो आप बोलोगे प्रॉब्लली मैलिग्नेंट स्वेलिंग है. फिर आप बोलोगे हम इस पेशेंट को एग्जामिन करेंगे. एग्जामिनेशन की फाइंडिंग्स क्या है, पहले देखोगे ये जो स्वेलिंग है ये ऊपर चलेगा बाय डिग्लूटिनेशन. कार्डिनल फीचर ऑफ थायराइड और थायराइड एसोसिएटेड स्वेलिंग क्या है, द स्वेलिंग मूव्स अपवर्ड्स विद डिग्लूटिनेशन. इफ अ स्वेलिंग मूव्स अपवर्ड्स विद डिग्लूटिनेशन उसका मतलब ये है कि वो थायराइड बेस्ड स्वेलिंग है, पहली बात. ठीक है, अच्छा दूसरा आप बोलोगे कि सरफेस कैसा है, जब आप सरफेस छू के देखोगे अगर वो स्मूथ और यूनिफॉर्म है तो बिनाइंग होगा, अगर नॉडुलैरिटी है तो प्रॉबेबली मैलिग्नेंट है। तो आपको ये दिमाग में रखना, आपको बताना है एग्जामिनर को, मुझे पता है कि एग्जामिन भी करना है। फिर आप बोलोगे कि कोई भी पेशेंट अगर सॉलिड थायराइड नॉड्यूल का आता है, कोई भी थायराइड स्वेलिंग, थायराइड स्वेलिंग्स में हमेशा आपको पता होना चाहिए कि पेशेंट यू थायराइड है, यू का मतलब थायराइड का लेवल नॉर्मल है, हाइपो का मतलब लेस कम सेक्रेशन हो रहा है, हाइपर का मतलब ज्यादा सेक्रेट हो रहा है। तो ये आप कैसे पता करोगे, वो आप टीएफटी के थ्रू करोगे, वो हम आगे बता रहे हैं, ठीक है। तो सॉलिटरी थायराइड नॉड्यूल में आपके तीन स्टेटस हैं, या तो हाइपो, यू, हाइपर हो सकता है। जब भी पेशेंट हाइपो और यू होगा वो प्रॉबेबली बिनाइंग या मैलिग्नेंट की वजह से होगा। बिनाइंग मतलब नॉर्मल लीजन, मैलिग्नेंट मतलब कैंसर। लेकिन अगर वो हाइपर थायराइडिज्म की वजह से था, वो उसका एक कंडीशन होता है टॉक्सिक एडिनोमा, आगे चल के बात करेंगे, एक और क्वेश्चन है, ठीक है। तो आपने इसको डिफरेंशियल बता दिया। आप बोलोगे कि इसको इन्वेस्टिगेट कैसे करोगे। कोई भी पेशेंट थायराइड स्वेलिंग के साथ आता है, तीन चीजें करनी है, टीएफटी थायराइड फंक्शन टेस्ट करना है, अल्ट्रासाउंड करना है, एफएनएससी करना है। हम एफएनएससी कौन से थायराइड स्वेलिंग्स में नहीं करेंगे, जहां पे वो हाइपर होगा, ठीक है। सो शुड बी डन, देखो एफएनएससी आप तभी करोगे जब वो यू या हाइपो होगा। हाइपर में एफएनएससी का कोई रोल है ही नहीं, क्यों? बिकॉज हाइपर थायराइड स्टेटस में जो स्वेलिंग्स होते हैं वो यूजुअली मैलिग्नेंट होते ही नहीं है। तो यू कैन बी लेस अबाउट इट। अब बारी है इसको मैनेज कैसे करोगे। डायग्नोस तो कर लिया, ठीक है, आपने अल्ट्रासाउंड किया, अल्ट्रासाउंड करने के बाद आपको पता चला आइसोलेटेड नॉड्यूल है, थायराइड फंक्शन टेस्ट में आपको रिपोर्ट आई कि यू या हाइपोथायराइड है, आपने एफएनएससी की। तो एफएनएससी में आपके पैथोलॉजिस्ट क्या रिपोर्ट देंगे, वो आपको बोलेंगे नॉन डायग्नोस्टिक। मतलब जो आप एफएनएससी कैसे करते हैं, यू टेक अ सिरिंज, यू टेक अ नीडल, यूजुअली 10 cc सिरिंज लेते हैं, 840 मीन यू कैन टेक एन 22 और 26 गेज नीडल लेते हैं, आप जहां पे स्वेलिंग है उसके अंदर डालोगे, उसको एस्पिरेट करोगे, एस्पिरेट करके ग्लास स्लाइड में डालोगे, पैथोलॉजिस्ट को दोगे, पैथोलॉजिस्ट देख के बताएगा। अब मान लो कि आपने सही जगह से एफएनएससी ली नहीं है, तो आपको मिल जाएगा नॉन डायग्नोस्टिक एस्पिरेट, तो आपका पैथोलॉजिस्ट बोलेगा भाई रिपीट करा ले, ठीक है। उसी का आप बोलेगा रिपीट अंडर, तो अल्ट्रासाउंड के थ्रू करेगा, तो मतलब यू डू मोर टारगेट ओरिएंटेड। फिर आती है बारी बिनाइंग लीजन है। बिनाइंग का मतलब कैंसर है ही नहीं, तो बिनाइंग में क्या है, सिस्ट का मतलब क्या होता है, फ्लूइड फिल्ड। सॉलिड का मतलब क्या होता है, इट इज एक्टिव प्रोलिफरेशन ऑफ सेल्स। अगर सिस्टिक है तो यूएसजी गाइडेड एस्पिरेशन, आप अल्ट्रासाउंड लोगे, नीडल डालोगे सिस्ट में, उससे फ्लूइड खींच लोगे, स्वेलिंग डिसअपीयर हो जाएगा। दूसरा है अगर सॉलिड है तो छोड़ दो, बिनाइंग ही है ना, कोई डरने की बात है ही नहीं, उसको बोलना आप आराम से ऑब्जर्व, मतलब हर साल एक बार आके अल्ट्रासाउंड करा लेना, ऑब्जर्वेशन। फिर एक और फाइंडिंग होती है एयूएस। एयूएस का मतलब होता है एटिपिया ऑफ अननोन सिग्निफिकेंस। इसका मतलब क्या है, पैथोलॉजिस्ट बोल रहा है सर देखो कुछ तो लोचा है, लेकिन वो सिग्निफिकेंट है कि नॉन सिग्निफिकेंट है, मतलब इज इट पॉइंटिंग टुवर्ड्स मैलिग्नेंस, इज इट पॉइंटिंग टुवर्ड्स बिनाइंग, मुझे समझ में नहीं आ रहा। तो आप बोलोगे देखो अगर समझ में नहीं आ रहा, मैं एक और बार आपको एफएनएससी करके दे देता हूँ, इस बार आप बेटर समझ लो, ठीक है। तो उसको बोलता है रिपीट एफएनएससी। यहां तक क्लियर है। फिर बारी आती है कि पेशेंट को हो सकता है रिपोर्ट आ जाए फॉलिकुलर नियोप्लाज्म। अभी जो फॉलिकुलर नियोप्लाज्म है ना, द वर्ड नियोप्लाज्म का मतलब होता है न्यू ग्रोथ। द वर्ड नियोप्लाज्म का मतलब होता है न्यू ग्रोथ, फॉलिकल से न्यू ग्रोथ आ रहा है। अब ये बिनाइंग है मैलिग्नेंट है, ये कैसे पता चलेगा। एक हमारे पास प्रॉब्लम है, रिमेंबर एफएनएससी जो है, एफएनएससी कैन नॉट डिफरेंशिएट, it cannot differentiate between a benign condition that is called as follicular adenoma and follicular carcinoma। तो जब भी आपका पैथोलॉजिस्ट रिपोर्ट देगा कि फॉलिकुलर नियोप्लाज्म है, वो आपको बताने की कोशिश कर रहा है कि मुझे समझ में नहीं आ रहा कि ये बिनाइंग है, इज इट एन एडिनोमा और इज इट अ कार्सिनोमा। तो उसके लिए क्या करोगे, ऐसे पेशेंट में you will take the patient for surgery and I am going to do something called as lobectomy। उसको आप फ्रोजन सेक्शन के लिए भेजोगे। नाउ ये फ्रोजन सेक्शन, ये कॉन्सेप्ट है ना, क्या है, लोबेक्टमी में आप जिस लोब में ट्यूमर है वो पूरा लोब ऑफ द थायराइड ग्लैंड निकालोगे, आप पैथोलॉजिस्ट को बोलोगे कि देन एंड देयर इटसेल्फ वो आपके स्लाइड्स बनाएगा और इवैल्यूएट करके बता देगा कि बिनाइंग है मैलिग्नेंट, एज सिंपल एज दैट। तो मतलब ये ड्यूरिंग द सर्जरी विद इन दी ओटी होता है, ताकि यू कैन टेक क्विक डिसीजंस, ठीक है। अगर बिनाइंग होगा तो बंद करके आ जाएंगे, मैलिग्नेंट होगा तो पूरा थायराइड ग्लैंड निकाल देंगे, एज सिंपल एज दैट। दिस इज अबाउट योर फॉलिकुलर नियोप्लाज्म, दैट इज अबाउट योर फॉलिकुलर नियोप्लाज्म। फिर पॉसिबिलिटी आती है कि आपका पैथोलॉजिस्ट बोलेगा सर इट इज सस्पिशियस ऑफ मैलिग्नेंसी, इट इज सस्पिशियस ऑफ मैलिग्नेंसी। नाउ इफ इट इज सस्पिशियस ऑफ मैलिग्नेंसी तो क्या करोगे, इसमें भी यही करोगे, सस्पेक्ट कर रहे हो ना, तो कंफर्म कैसे करोगे? कंफर्म आप करोगे लोबेक्टमी विथ फ्रोजन सेक्शन। और लास्ट एंड द मोस्ट इंपॉर्टेंट वन, अगर रिपोर्ट आती है कि दिस इज अ मैलिग्नेंट लीजन, अगर वो मैलिग्नेंट लीजन है तो स्टेज वाइज मैनेजमेंट करेंगे, खत्म बात। ओके if it is a malignant lesion, then here it has to be stage wise management. This is going to be stage wise management. Clear है? तो जब भी आपके पास क्वेश्चन आएगा सॉलिटरी थायराइड नोड्यूल को मैनेज कैसे करना है, ये टेबल आपको डालना है। अगर आपको थोड़े पॉइंट्स एक्स्ट्रा कमाने, आपको अगर यू हैव टू इम्प्रेस योर एग्जामिनर, इसको बोलते हैं बेथसिडा क्लासिफिकेशन। जो भी हमने सीखा पूरा मैनेजमेंट प्रोटोकॉल नो, इसको बेथसिडा क्लासिफिकेशन बोलते हैं। तो थोड़ा इसमें अगर मिर्ची डालनी है कि दैट यू आर ट्राइंग टू इम्प्रेस योर एग्जामिनर कि क्या है, तो आप बोलोगे ये बेथसिडा क्लासिफिकेशन है, एज सिंपल एज दैट। ठीक है। सो आज का हमारा पहला टॉपिक था सॉलिटरी थायराइड नोड्यूल पे अगर नोट डालना है तो दिस इज व्हाट यू हैव टू राइट फॉर 5 मार्क्स। ठीक है, तो इतना डाल दोगे, इट इज मोर देन इनफ। एग्जामिनर इज क्वाइट इम्प्रेस्ड कि यार इस बच्चे को सब कुछ आता है। क्लियर है? ठीक है, ठीक है, कैन यू मूव ऑन? ग्रेट। तो अभी हमारा सेकंड क्वेश्चन क्या है? सेकंड क्वेश्चन अगेन इंपॉर्टेंट वन, हम बात करेंगे थायरोटॉक्सिकोसिस की। ठीक है, तो बात करते हैं थायरोटॉक्सिकोसिस। So the second question that you have is of thyrotoxicosis. ठीक है, so thyrotoxicosis is basically a thyroid swelling associated with hyperthyroid status. ठीक है, so thyrotoxicosis is hyperthyroidism associated with thyroid swelling. So हमारी ओपनिंग लाइन हो जाएगी कि thyrotoxicosis basically defines as hyperthyroidism associated with thyroid swellings is what we call as thyrotoxicosis. This is what we call as the thyrotoxicosis. ठीक, तो आप बोलोगे thyrotoxicosis ना can be divided into two varieties. This is what we call it as the primary thyrotoxicosis, another one is a secondary thyrotoxicosis. So दो differential points में बात करेंगे. Number one is going to be the primary thyrotoxicosis and the secondary thyrotoxicosis. The primary thyrotoxicosis and the secondary thyrotoxicosis. So the primary thyrotoxicosis and the secondary thyrotoxicosis, right? What is the definition behind this? A primary thyrotoxicosis, in a primary thyrotoxicosis there are signs and symptoms. The signs and symptoms of hyperthyroidism. Signs and symptoms of hyperthyroidism arise first and then followed by development of thyroid swelling, then followed by the development of thyroid swelling. It is then followed by the development of the thyroid swelling. This is called as primary thyrotoxicosis. Sir, will there always be a swelling associated with thyrotoxicosis? But usually if you're saying swelling with hyperthyroidism, then it is thyrotoxicosis. Otherwise, it will be called as hyperthyroidism. Okay? So that is why, when the word thyrotoxicosis, that means toxic status itself indicates hyperthyroidism. So why it is happening? It is secondary to a swelling that is arising into the thyroid gland. So you're interpreting that swelling to cause the thyrotoxicosis, right? So it is a non-componental form of hyperthyroidism. That means the primary condition is within the thyroid gland. So that is why we call it as thyrotoxicosis. In secondary thyrotoxicosis, it will be thyroid swelling. Here the thyroid swelling arise first. It arises first, then followed by signs and symptoms. Then followed by the signs and symptoms of hyperthyroidism. Signs and symptoms of hyperthyroidism. This is what we call it as secondary thyrotoxicosis. ठीक है? तो प्राइमरी और सेकेंडरी में फर्क क्या है? प्राइमरी में थायरोटॉक्सिकोसिस, हाइपरथायराइड के फीचर्स पहले आएंगे, स्वेलिंग बाद में आएगा. लेकिन वही अगर आप देखोगे सेकेंडरी थायरोटॉक्सिकोसिस में क्या है कि पहले थायराइड स्वेलिंग आएगा, उसके बाद सिम्टम्स आएंगे टॉक्सिकोसिस के. अगर टॉक्सिकोसिस पहले है, स्वेलिंग बाद में है, तो प्राइमरी है. अगर स्वेलिंग पहले है, सिम्टम्स ऑफ टॉक्सिकोसिस बाद में, तो सेकेंडरी. इतना सिंपल है. तो सिम्टम्स, स्वेलिंग प्राइमरी, स्वेलिंग देन सिम्टम्स, दैट इज सेकेंडरी. सिंपल है. ठीक है, ये आप नहीं भूलना. दिस इज द मोस्ट इंपॉर्टेंट थिंग. सो द फर्स्ट थिंग, तो आपके एग्जामिनर को क्लियर कट आइडिया कि इस बच्चे को पता है कि प्राइमरी और सेकेंडरी थायरोटॉक्सिकोसिस में फर्क क्या होता है. नाउ यही थायरोटॉक्सिकोसिस के व्हाट आर द कॉजेस. सो वी टॉक अबाउट द कॉजेस ऑफ थायरोटॉक्सिकोसिस. द कॉजेस ऑफ thyrotoxicosis. When you look at the causes of the thyrotoxicosis, we can divide them into three major causes that we can talk about it. Number one, it can be because of the Graves' disease. Number two, it can be because of the Plummer's disease. And number three, it is because of autonomous. It is because of an autonomous adenoma. It is because of autonomous adenoma, right? So usually you should be able to answer these three findings that are present. ठीक है? So again, हमारा यही है कि सारे आंसर्स आप टेबल या कंपैरेटिव स्केल में दोगे ताकि आपका एग्जामिनर इम्प्रेस्ड रहे. ठीक है. सो विल टॉक अबाउट ग्रेव्स डिजीज, वी टॉक अबाउट द प्लमर्स डिजीज, एंड वी टॉक अबाउट द टॉक्सिक एडिनोमा. ठीक है. चलो. सो ग्रेव्स डिजीज इज ऑल्सो रेफर्ड टू एज, इसके ऑल्टरनेट नेम्स देख लेते हैं. ग्रेव्स डिजीज ऑल्सो नोन एज, this will be also known as diffuse toxic goiter. This is what we call as diffuse toxic goiter. This is what we call it as a toxic multinodular goiter. This is your toxic multinodular goiter, and this is what we call it as toxic adenoma. Right? Graves is an example of, it is an example of primary thyrotoxicosis. It is an example of primary thyrotoxicosis. Toxic multinodular goiter, it is an example of secondary thyrotoxicosis. It is an example of secondary thyrotoxicosis. ठीक है? So when you look at this, sorry. Now, Graves is what we call it as the primary thyrotoxicosis. Plummers is what we call it as the secondary thyrotoxicosis. ठीक है? Now, इनके specific causes क्या हैं? So when you look at the Graves disease, Graves is an autoimmune disorder. right? Plummer's disease, it is because of long standing, untreated, goiter. This is your plumber's disease. Autonomous adenoma क्या है? इसका रीजन मुझे भी नहीं पता है, किसी को भी नहीं पता. It is idiopathic. It is going to be idiopathic. Just give me a second, guys. I'm getting a repeated call. Just hold on for a second. Okay, guys. So the causes for Graves, it is going to be autoimmune. Plumbers, it is going to be your long-standing untreated goiter. For toxic adenoma, it is going to be idiopathic. Okay. Now let's talk about the pathophysiology. Now Graves, because it is an autoimmune disorder, it will be associated with an antibody. Now remember, the antibody that is going to be formed in Graves' disease goes by the name as LATS. Now what is LATS stands for? LATS is your long-acting, it is going to be long-acting thyroid stimulating antibody. There is going to be a long-acting thyroid stimulating antibody, right? Now, what is the pathophysiology of Plummer's disease? It is not understood, so it is unknown pathophysiology. But it has been noticed that 30% of multinodular goiter, they present as secondary thyrotoxicosis. Autonomous adenoma ka pathophysiology is again unknown because the cause is idiopathic. It is unknown. But what you can say in autonomous adenoma is, we call it as autonomous because it is independent. It is independent of TSH. It is an independent of TSH. That means, see, for every follicle to release a T3, T4 hormone into the circulation, you require a thyroid stimulating hormone to come and attach to that of the thyroid follicular cell so that it it releases it. Whereas in a toxic adenoma, it is not reliant on, or it is not basically waiting. It is not currently, it is not waiting for a TSH to come, stimulate it, and then produce it out. Okay. Okay. Clear, guys, right? Elevate, thank you so much. Chalo. The app is updating, can't help it. Give me 1 second. Okay. Clear. Now this is with respect to Graves, Plummer's disease as well as autonomous adenoma. Ye iske pathophysiologies hai. Now if you dig a little bit deep into the pathophysiology, let's understand ki how does it happen so. Now, how does it happen so? Okay. So you'll write about the components, the causes, the pathophysiology, and all this you have already mentioned. Okay. Now we'll talk about the clinical features of each one of them. So in clinical features, what do you see in the Graves disease? Now, Graves is a primary thyrotoxicosis. Primary का मतलब क्या है? First, there will be signs and symptoms of hyperthyroidism. So, there will be presence of signs and symptoms. There are signs and symptoms of hyperthyroidism. The signs and symptoms of hyperthyroidism. Second, it is going to present to you as goiter-like swelling. Now, इससे पहले I've just explained you कि goiter का मतलब क्या है? There's a generalized enlargement of the thyroid gland. So there'll be signs and symptoms of hyperthyroidism, and it is going to present to you as goiter-like swelling, right? So there will be, if you talk about what is goiter-like swelling, a quick word on goiter you can say. It will present to you as midline neck swelling. It will present to you as a midline neck swelling. This midline neck swelling is going to remain painless. It is going to gradually increase in size. This is going to gradually increase in size. Along with increase in size, it is also going to, when you talk about it in terms of enlarged gland, because it's a goiterous gland, no, it is going to enlarge. Now, once it is going to enlarge, so there's a midline neck swelling, there's going to remain painless. It gradually increases in size. Now, as it increases in size, it can also, cause a little bit of compressive component also. So it will be associated, can also result in pressure symptoms. Now, what are pressure symptoms is, whenever a thyroid gland enlarges, no, because it's present right in the center, it is going to exert pressure onto the trachea. ट्रेकिया कंप्रेस हो जाएगा तो सांस लेने में दिक्कत होगी, तो इसको डिस्निया बोलते हैं. ट्रेकिया के पीछे आपका ईसोफेगस है, ईसोफेगस कंप्रेस हो जाएगा तो स्वॉलो करने में डिफिकल्टी हो जाएगा, जिसको डिस्फेजिया बोलते हैं. अब ट्रेकिया और ईसोफेगस के बीच में ना रेकरेंट लैरिंजियल नर्व होती है, अगर वो कंप्रेस होगी, रेकरेंट लैरिंजियल नर्व के कंप्रेशन की वजह से होर्सनेस ऑफ वॉइस देखने को मिलेगा. और ये सिम्टम्स अगर प्रेजेंट है तो आप इसको प्रेशर सिम्टम्स बोलते हो, राइट. सो इट इज गोइंग टू हैव गोइटर लाइक प्रेजेंटेशन. गोइटर लाइक में इसमें मिडलाइन नेक स्वेलिंग हो गया, पेनलेस हो गया, ग्रेजुअली इंक्रीजिंग इन साइज, प्रेशर सिम्टम्स देखने को मिलेंगे. दैट इज गोइंग टू बी इन योर ग्रेव्स डिजीज. जब ग्रेव्स डिजीज का पेशेंट एग्जामिन करोगे, यू विल नोटिस इट इज गोइंग टू हैव स्मूथ सरफेस. इट इज गोइंग टू हैव अ स्मूथ सरफेस. और वन मोर इंपॉर्टेंट थिंग, बिकॉज द वास्कुलरिटी ऑफ द ग्लैंड. अब ग्रेव्स में क्या है, बिकॉज ऑल दीज लैच नो लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडीज, बिकॉज ओवर स्टिमुलेशन विच इज कॉज एक्सेसिव ग्रोथ और एक्सेसिव प्रोलिफरेशन ऑफ द फॉलिकुलर सेल्स, तो नियोवास्कुलराइजेशन होता है, ज्यादा ब्लड वेसल्स आते हैं. बिकॉज ऑफ इंक्रीज वास्कुलरिटी ऑफ द ग्लैंड्स इन द ग्रेव्स डिजीज, ब्लड इज रिस्पॉन्सिबल फॉर कैलोरीजेनेसिस, नो. सो यू विल सी प्रेजेंस ऑफ वार्म सरफेस ऑल्सो, इट इज गोइंग टू बी वार्म सरफेस. तो यहाँ पे टेम्परेचर भी एलिवेटेड देखने को मिलेगा, राइट. सो इट इज गोइंग टू बी स्मूथ एंड इट इज ऑल्सो गोइंग टू बी वार्म सरफेस. ठीक है. When it comes down to your plumber's disease, that is secondary thyrotoxicosis, patient is going to present to you with multinodular goiter-like presentation. So in a multinodular goiter-like swelling, what is going to happen? Everything will remain same, right? It will also present to you as midline neck swelling. This is also going to be as a midline neck swelling. This will also remain painless. This will also gradually increase in size. This will also gradually increase in size. This will also be associated with same pressure symptoms. This will also be associated with same pressure symptoms. On examination, this is where you will have nodular surface. There is no altered temperature. There is no altered skin temperature. That means, like in Graves, no, it feels warm. Here it is nothing. And this is going to move upwards. This swelling is going to move upwards with deglutination. This is going to move upwards with deglutination. Obviously, your Graves disease is also going to move upward with deglutination. This is also going to move upwards with deglutination. Okay? So these are the differentiating factors between each of them. Toxic adenoma में क्या लिखोगे? Toxic adenoma में, obviously, another finding in your plumber's disease will there be presence of signs and symptoms. The signs and symptoms of hyperthyroidism. देयर इज साइंस एंड सिम्टम्स ऑफ हाइपरथायरॉइडिज्म। ठीक है, तो इसका कहने का मतलब क्या है? प्राइमरी में आपने बताया, देखो अगर आप प्राइमरी देखो ना, पहले सिम्टम्स ऑफ हाइपरथायरॉइड फिर स्वेलिंग आया। सेकेंडरी में क्या है, पहले स्वेलिंग आया फिर सिम्टम आया। ये जब लिखोगे आपका एग्जामिनर ऑलरेडी इंप्रेस्ड है, मतलब वो तो बोलेगा कितना ऑसम है ना, और वो फिर पूरे मार्क्स दे देगा। टॉक्सिक एडिनोमा में क्या है? टॉक्सिक एडिनोमा में पेशेंट विल प्रेजेंट टू यू विथ सॉलिटरी thyroid nodule like presentation. It will present to you as solitary thyroid nodule like swelling. Now ये जो solitary thyroid nodule like swelling होगी, this will also be present in the midline of the neck. This will also present as midline neck swelling. This will also remain painless. इसका जो ग्रोथ पैटर्न होगा वो भी सेम. दिस इज गोइंग टू बी ग्रेजुअली इंक्रीजिंग इन साइज. इट विल बी ग्रेजुअली इंक्रीजिंग इन साइज. देयर आर नो प्रेशर सिम्टम्स, बट यहाँ पे आप देखोगे दैट यूजुअली इट विल बी एसोसिएटेड विद अ स्मूथ सर्फेस. Usually it is associated smooth surface, and there will be signs and symptoms. There will be signs and symptoms. There will be signs and symptoms of hyperthyroidism. There will be signs and symptoms of hyperthyroidism. ठीक है, so these are all in favor of three distinctive presentation. ठीक है, अब ग्रेव्स में ना when you look at the differentiating findings as well, अब क्या differentiate करोगे? In Graves, we'll talk about the age of presentation, which is the most likely sex to be involved, other findings that we're going to talk about it. ठीक है, तो फिर आप यहाँ पे now you'll say what is the age of presentation of each of them, right? So when you talk about Graves, it is an autoimmune disorder. Graves वाला जो patient है, it is usually seen between the second to third decade of life, so usually between 20 to 30 years. Plummer's disease is usually seen in 4th to 5th decade of life, that is between 40 to 50 years, right? 40 to 50 years. Toxic adenoma can be seen at any age group. It can be seen at any age group. So when you talk about which is the more likely sex to be involved, remember in all these disorders, it is female which are more likely to be involved when compared to males. You will say it is the female that is more likely to be involved when compared to males, as simple as that. Now, something really interesting and important that you should know, it is going to be the extra thyroid manifestation. So when you talk about the extra thyroid features rather than saying manifestations, we talk about extra thyroid features. Now the most common disease among all these three which has extra thyroid manifestations is the Graves disease. So Graves में ना, when you look at it, the extra thyroid manifestation, number one, it is associated with Graves ophthalmopathy. Now this Graves ophthalmopathy basically means what? The Graves ophthalmopathy is nothing but eggs of thalamus. If your examiner asks why is there an exophthalmos that is going to occur. Now the basic concept for development of an exophthalmos is, if you take this as a representation of the orbit of the eye. अब ये जो orbit है ना eye का, it is a bony cavity or it is a very limited space. It only have 30 cc, मतलब इतना ही space है. इसी orbit के अंदर you will find that the human eye is present. So this is a representation of the human eye. अब eye जो है इसी orbit के अंदर fit है. अब along with the eye being inside this orbit, जितने भी आपके ocular muscles हैं. Now we talk about the ocular muscles. You have the superior oblique. You have the superior rectus, inferior rectus. You have the medial rectus as well as the lateral rectus, the superior oblique and the inferior oblique, right? So superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. These are the 6 rectus muscles that are present. The problem is all these antibodies which are present, as we have discussed it, the antibodies that are developed here, these are what we call it as the long-acting thyroid stimulating antibodies. Now these LATs antibodies, sometimes they get misdirected and they go attack the ocular muscles. Now they perceive the ocular muscles as a foreign, so वो जाके ocular muscles को attack करते हैं. When they attack the ocular muscles में what is going to happen? It is going to result in inflammation. ठीक है? That injured ocular muscle will result in development of retroorbital edema. ये जो inflammation हुआ ना, इस inflammation की वजह से this antibodies which have attacked the ocular muscles, there will be a lot of fluid that is going to get deposited that is causing retroorbital edema. अब ये retroorbital edema की वजह से क्या हो रहा है? It is now pushing the eyeball forward. So जितना भी fluid accumulated है, it is going to push the eyeball forward. Now as the eyeball has been pushed forward, it is going to protrude out of the eyeball or the orbit. Now as the eyeball protrudes out of the orbit, this protrusive eyeball is what we call it as exophthalmos. So exophthalmos in Graves' disease is because of the cross-reacting antibodies injuring or attacking the ocular muscles. So ये आपका पहला हो गया, that is Graves' ophthalmopathy. इसके साथ साथ you will see presence of Graves' dermopathy. So skin differentiation होगा, that is Graves' dermopathy is there. Then there will be development of thyroid acropathy. Now this thyroid acropathy is basically formation of new bones in the metacarpals. It is basically the formation, there is formation of new bones in metacarpal. There is formation of new bones in the metacarpal, that is because of excessive calcium deposits. ठीक है? So Graves' ophthalmopathy होगा, Graves' dermopathy, thyroid acropathy. It is also associated with gynecomastia. It is also associated with gynecomastia. ठीक है? So these are the important extra thyroid manifestations that you have. There are no specific extra thyroid manifestations that you will see in these two. So extra thyroid manifestations, usually they are seen in Graves' disease, right? Now, when you talk about the hyperthyroidism, which system is involved in hyperthyroid features? Okay? So when you talk about the most common system involved in each of these diseases, that is also an important question to be analyzed. So the most common system that is going to be evaluated on, ठीक है? Most common system कौन सा है? The most common system, when you look at the component here, the most common system involved which is going to be involved, remember for Graves' disease, it is going to be CNS. This is going to be cardiovascular system. Here, not any one particular system is usually involved. ठीक है? So you will have more of CNS features in Graves. CNS features क्या यार? Hyperthyroid के features है ना? Irritability, anxiety, insomnia, all that is more common in your Graves' disease. CVS के क्या? Palpitation, tachycardia. The patient is going to have high perfusion. Sympathetic overdrive. No, so there's excessive perfusion. So patient is going to be sweating a lot. All these are more common in your Plummer's disease. Now, जब भी आपके पेशेंट आते हैं with thyrotoxicosis, सारे फीचर्स थायराइड स्वेलिंग के साथ है, तो इसमें आप इन्वेस्टिगेशन क्या करोगे? सेकंड नेक्स्ट थिंग दैट वी आर गोइंग टू टॉक अबाउट, द पेशेंट इज प्रेजेंटेड विद ऑल दीज सिम्टम्स, व्हाट इज गोइंग टू बी आवर इन्वेस्टिगेशन? नाउ इन्वेस्टिगेशन फॉर ऑल थायराइड स्वेलिंग, चाहे आप कोई भी थायराइड स्वेलिंग उठा के देख लो, इन्वेस्टिगेशन का जो प्रोटोकॉल है दैट इज गोइंग टू बी क्वाइट स्टैंडर्ड. सबसे पहले आप द फर्स्ट थिंग दैट आई एम गोइंग टू डू इज गोइंग टू बी थायराइड फंक्शन टेस्ट. सो इन सब में आप थायराइड फंक्शन टेस्ट, in all these the first test that I'm going to do is going to be thyroid function test. ठीक है? जब आप देखोगे थायराइड फंक्शन टेस्ट में क्या मेजर कर रहे हो, यू आर लुकिंग एट द T3 लेवल, यू आर लुकिंग एट द T4 लेवल, यू आर लुकिंग एट द TSH. नाउ ग्रेव्स में देयर इज एन एंटीबॉडी, राइट? That antibody is causing overstimulation of the T3 follicles. So there's one excessive release of T3 T4. जब excessive release of T3 T4 होगा, negative feedback की वजह से क्या होगा? The TSH is going to drop. So this is how the picture of your hyperthyroid status would look like. तो सेम यहाँ पे भी आप वही देखोगे, T3 आप देखोगे, you will measure the T4 and you will measure the TSH. Here also you're going to do the same thing. You're going to measure the T3 level, you're going to measure the T4 level, you're going to measure the TSH level. Now, what is going to happen in your secondary thyrotoxicosis? Now, in secondary thyrotoxicosis, this, excessive release of T3, T4 from the nodular status itself. जब जैसे ये T3, T4 excess release करेगा, negative feedback से TSH drop करेगा. ऑटोनमस एडिनोमा में क्या है? दी एडिनोमा विच इज फॉर्म, वो अपने आप से ही हार्मोन बना रहा है और रिलीज किए जा रहा है, और जैसे जैसे रिलीज करेगा वैसे वैसे T3 T4 का लेवल इंक्रीज करेगा, TSH का ड्रॉप करेगा. तो बेस्ड अपॉन द TFT मैं थोड़ा डिफरेंशिएट कर सकता हूँ कि ग्रेव्स डिजीज है और इट इज गोइंग टू बी अ प्लमर्स डिजीज और इट इज गोइंग टू बी टॉक्सिक एडिनोमा. तो अब नेक्स्ट क्या करोगे? द सेकेंड इन्वेस्टिगेशन दैट आई एम गोइंग टू डू हियर, इट इज गोइंग टू बी अल्ट्रासाउंड. तो अल्ट्रासाउंड में फाइंडिंग क्या मिलेगी? ग्रेव्स में आपको स्मूथ सरफेस मिलेगा. यहां पे जब आप अल्ट्रासाउंड करोगे यू विल सी नॉड्यूलर सरफेस. सो यू विल सी लॉट ऑफ नॉड्यूल्स आर गोइंग टू बी प्रेजेंट. वेराज यहां पे जब आप अल्ट्रासाउंड करोगे टॉक्सिक एडिनोमा में, इट इज यूजुअली सॉलिटरी नॉड्यूल दैट इज गोइंग टू बी प्रेजेंट. दिस विल बी एसोसिएटेड सॉलिटरी नॉड्यूल. ग्रेव्स में जब अल्ट्रासाउंड करोगे एक और एडिशनल फाइंडिंग मिलेगी, देयर विल बी इंक्रीज्ड वास्कुलैरिटी ऑफ द ग्लैंड. देयर विल बी इंक्रीज्ड वास्कुलैरिटी ऑफ द ग्लैंड. ठीक है. whereas here there is no other component. In this you can also see presence of colloid rich nodules. you see colloid rich nodules. ठीक है. अब आपको पता है there is no role when you come to this, there is no role of FNSC क्योंकि ये टॉक्सिक स्वेलिंग्स है. जब टॉक्सिक स्वेलिंग्स में आप पता है कि मुझे यहाँ से डिटरमाइन हो गया ना, जैसे ही मैंने इसका TFT करा है मुझे पता है कि ये तीनों स्वेलिंग्स जो मेरे पास हैं ऑल ऑफ देम आर ऑफ हाइपरथायराइड, क्योंकि सब में देख रहे हो आप T3 T4 तो एलिवेटेड है, जहाँ जहाँ T3 T4 एलिवेटेड होगा वो थायराइड टॉक्सिक स्वेलिंग हो जाएगा. अब स्वेलिंग टॉक्सिक है तो आई नो इट कैन नॉट बी मैलिग्नेंट, तो FNSC करने की जरूरत है ही नहीं. अब बारी है कि तीसरा इन्वेस्टिगेशन क्या करोगे. The third investigation that I'm going to do is going to be a radioactive iodine scan, and the isotope that I'm going to use is iodine 123. तो इन सब में I am going to do a radioactive iodine scan with iodine 123. तो इतना याद कर लेना कि डायग्नोसिस में हम हमेशा iodine 123 यूज करते हैं. आयोडीन 123 का हाफ लाइफ 13 आवर्स होता है. आई डोंट थिंक इट इज इंपॉर्टेंट, लेकिन अगर आपको इंप्रेस करना है इतना लिखना, टी हाफ ऑफ आयोडीन 123 इज गोइंग टू बी 13 आवर्स एंड इट इज गोइंग टू एमिट बीटा रेडिएशन. सॉरी, इट इज गोइंग टू एमिट गामा रेडिएशन. इट इज गोइंग टू एमिट गामा रेडिएशन. आयोडीन 131 बीटा और गामा दोनों रेडिएट करता है, लेकिन आयोडीन 123 ओनली एमिट्स दी गामा रेडिएशन. ठीक है, इतना क्लियर है. अब रेडियो एक्टिव आयोडीन में आपको कैसे पता चलेगा कि यू आर लुकिंग एट ग्रेव्स डिजीज और यू आर लुकिंग एट योर प्लमर्स डिजीज और टॉक्सिक एडिनोमा. बड़ा सिंपल और प्यारा सा कॉन्सेप्ट है. ठीक है, जस्ट 2 मिनट में एक्सप्लेन कर दूंगा, यू विल बी एबल टू अंडरस्टैंड इट बेटर. मान के चलिए ये इस्थमस है, ये आपका लेफ्ट लोब है, ये आपका राइट लोब है. दिस इज द राइट लोब ऑफ द थायराइड ग्लैंड, दिस इज द लेफ्ट लोब ऑफ द थायराइड ग्लैंड. ठीक है. वी ऑल नो कि थायराइड ग्लैंड के अंदर यू हैव दीज फॉलिकल्स विच आर प्रेजेंट. अब आप जो आयोडीन दोगे वो फॉलिकल के अंदर ही जाएगा. अब जब आप जो आयोडीन दे रहे हो या आप रेडियो एक्टिव आयोडीन दे रहे हो, तो यू कैन मेजर द अपटेक ऑफ आयोडीन बाय लुकिंग एट अ रेडियो स्कैनर, जिसको आप गामा कैमरा बोलते हो. तो अब क्या करोगे कि ग्रेव्स डिजीज में हुआ क्या? ग्रेव्स डिजीज में ये जो लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडीज हैं वो आके थायराइड फॉलिकल को स्टिमुलेट कर रहे हैं. ठीक है. नाउ व्हाट इज गोइंग टू हैपन इज, नाउ एज देखो, अ वेरी वेरी ब्यूटीफुल कॉन्सेप्ट है. TSH के ना, दैट इज थायराइड स्टिमुलेटिंग हार्मोन के 2 फंक्शंस हैं. एक फंक्शन ये है कि इट स्टिमुलेट्स द थायराइड फॉलिकल्स टू रिलीज T3 T4. सेकंड, जब भी TSH एक्सेस में होता है ना, इट प्रमोट्स ग्रोथ. अभी जो एंटीबॉडी बनी है ना, लॉन्ग एक्टिंग थायराइड स्टिमुलेटिंग एंटीबॉडी, इट मिमिक्स लाइक TSH, वो दिखने में TSH की तरह होती है. तो जब फॉलिकल्स के पास आपका एंटीबॉडी और TSH दोनों गए, तो फॉलिकल को तो पता ही नहीं है कि कौन सा एंटीबॉडी है कौन सा TSH है, तो एंटीबॉडी जाके फॉलिकल को बाइंड कर जाता है. अब फॉलिकल को तो लगता है कि यार ये तो अपना TSH है. अब ये तो वही होगी ना चोर चाबी. ठीक है, यू हैव टू डुप्लीकेट की, डुप्लीकेट से भी ताला खुलेगा, ओरिजिनल की से भी खुलेगा. अब ये एंटीबॉडी आके अटैच कर गई, जब अटैच कर गई वो जाके फॉलिकल को बोलिए कि रिलीज कर, T3 T4 रिलीज करते हैं, तो एक्सेसिव रिलीज ऑफ T3 T4 हो रहा है। अब ये जो TSH पड़ा हुआ है वो क्या करेगा, अब TSH जब, अब देखो T3 T4 रिलीज होता रहा है क्योंकि एंटीबॉडीज बाइंड कर रहे हैं और बॉडी को लग रहा है कि ऑब्वियसली देयर इज एन एक्सेसिव स्टिमुलस, और जो बचा हुआ सर्कुलेटिंग TSH होता है ऐसे ही पड़ा हुआ है, एंड दैट TSH बिकॉज देयर इज एक्सेसिव स्टिमुलेशन ऑफ द फॉलिकल्स। अब फॉलिकल को लग रहा है कि अगर ये बार बार एंटीबॉडी आके स्टिमुलेट कर रहा है ना, फॉलिकल को थोड़ा पता है ये एंटीबॉडी है, फॉलिकल को लग रहा है कि ये तो TSH है, और एक्सेसिव TSH, जब TSH बोलेगा, अब देखो जब तक इसके अंदर हार्मोन है निकलता रहेगा, जब हार्मोन खत्म हो गया उसके बाद अगर फॉलिकल को स्टिमुलेट करेगा ना, तो फॉलिकल को लगेगा ये TSH पागल हो गया, इसको लग रहा है कि ना ज्यादा चाहिए। अब ज्यादा चाहिए तो फॉलिकल बोलता है अरे मेरे को ज्यादा T3 T4 बनाना है, क्या करें, फॉलिकल विल स्टार्ट प्रोलिफरेटिंग, फॉलिकुलर सेल्स विल स्टार्ट टू इंक्रीज। अब जब फॉलिकुलर सेल्स इंक्रीज करेंगे तो साइज तो इंक्रीज करेगा ना भाई, जब साइज इंक्रीज करेगा दिस इज गोइंग टू एनलार्ज, अब ये हो जाएगा एनलार्ज लाइक दिस, इसीलिए इसको बोलते हैं डिफ्यूज टॉक्सिक गोइटर। डिफ्यूज मतलब पूरा ग्लैंड एनलार्ज हो गया, राइट। नाउ बिकॉज ऑफ दिस यू विल सी ऑल दिस फॉलिकल्स हैव प्रोलिफरेटेड। अब क्योंकि सारे फॉलिकल्स प्रोलिफरेट हुए इसलिए तो ग्लैंड एनलार्ज हुआ है, एंड दिस इज व्हाट वी कॉल इट एज डिफ्यूज टॉक्सिक गोइटर। नाउ दिस इज व्हाट वी कॉल इट एज द डिफ्यूज टॉक्सिक, दिस इज व्हाट वी कॉल इट एज डिफ्यूज टॉक्सिक गोइटर। Now जब आप रेडियो एक्टिव आयोडीन दोगे ना, रेडियो एक्टिव आयोडीन इज गोइंग टू गो एंड गेट इनटू दीज फॉलिकल्स। तो नॉर्मली में अगर आप में और मेरे में रेडियो एक्टिव आयोडीन दोगे तो उसका अपटेक कुछ ऐसा होगा, ठीक है। सो दिस इज द नॉर्मल अपटेक ऑफ अ रेडियो एक्टिव आयोडीन फॉर यू एंड मी अगर ग्लैंड नॉर्मल है। लेकिन अगर वही ग्रेव्स डिजीज में इनलार्ज होगा, यू कैन सी देयर इज अ लॉट ऑफ प्रोलिफरेशन, यू विल नाउ नोटिस कि ये पूरा जो ग्लैंड है ना, इट इज नाउ गोइंग टू हैव a lot of radioactive iodine is been uptaken। तो आप देखोगे ग्लैंड में ना रेडियोएक्टिव आयोडीन का अपटेक और इसका कॉन्सेंट्रेशन बढ़ जाएगा, और ये जब गामा कैमरा में देखोगे उसकी इमेज कुछ ऐसे नजर आएगी, दिस अ डिफ्यूज एक्सेसिव अपटेक। तो डिस्क्राइब करते हैं आपके रेडियोलॉजिस्ट बोलते हैं कि ये डिफ्यूज अपटेक है, देयर इज एन एक्सेसिव अपटेक एंड देयर इज अ यूनिफॉर्म अपटेक, देयर इज अ यूनिफॉर्म अपटेक। अगर ऐसा कोई अपटेक आपको मिल रहा है जहां पे नॉर्मल से ज्यादा है और पूरे ग्लैंड में यूनिफॉर्मली एक तरह से अपटेक हो रहा है, देयर इज अ यूनिफॉर्म अपटेक थ्रू आउट द ग्लैंड, एंड इफ यू सी देयर इज एन हाइपर अपटेक, देयर इज ओनली वन डायग्नोसिस दैट इट गोज इन फेवर ऑफ, दैट इज गोइंग टू बी योर डिफ्यूज टॉक्सिक गोइटर। और ये जो डिफ्यूज टॉक्सिक गोइटर है, इट इज नथिंग बट योर ग्रेव्स डिजीज, एंड ऑफ डिस्कशन। तो अगर आप सिर्फ ऑरेंज ऑरेंज देखो और कुछ मत देखो, यहाँ पे इतना कम ऑरेंज दिख रहा है, यहाँ पे भर भर के ऑरेंज दिख रहा है, अब दैट एक्सेसिव ऑरेंज, दैट इज दिस इज टू डिपेक्ट यू कि रेडियोएक्टिव आयोडीन कितना ज्यादा अपटेक हो गया। सो इतना हाई अपटेक देखने को मिलेगा ना, दिस इज गोइंग टू बी योर ग्रेव्स डिजीज। अब बारी आती है हमारे टॉक्सिक मल्टीनोडुलर गोइटर में। अगर पैथोफिजियोलॉजी देखोगे ना टॉक्सिक मल्टीनोडुलर गोइटर की, उसमें कुछ ऐसा होगा, ग्लैंड विल हैव अ नोडुलर सरफेस, ग्रेव्स में तो यूनिफॉर्म स्मूथ है। अब ये नोडुलर क्यों है, देयर आर फ्यू साइट्स which are going to have a fibrosed follicles। तो यहाँ पे कुछ sites of the gland is having this fibrosis and these are called as fibrosed follicles, or there are some follicles which are going to have excessive proliferation, and this is what we call it, wherever there is an excessive proliferation there will be excessive growth, and that excessive growth is what is resulting in nodularity, that is where it will be present as nodularity. Now because obviously all these nodules are because of excessive proliferation, so when you give radioactive iodine here, so you will see there's a lot of radioactive iodine has been uptaken here. लेकिन if you compare that with the Graves disease, तो फर्क क्या देखने को मिल रहा है, आप देखोगे Graves disease में पूरे ग्लैंड में यूनिफॉर्मली अपटेक है, लेकिन प्लमर्स डिजीज में कुछ जगह पे बहुत ज्यादा अपटेक और कुछ जगह पे बिल्कुल अपटेक है ही नहीं, there's no uptake here, there's no uptake here, there's no uptake here, there's no uptake, so there's a patchy uptake, है ज्यादा, जहां पे भी अपटेक है वहां पे है ज्यादा, लेकिन जहां पे अपटेक नहीं बिल्कुल नहीं है। सो दिस पैची अपटेक विद एक्सेसिव अपटेक इन फ्यू एरियाज इज एन इंडिकेशन ऑफ टॉक्सिक मल्टीनोडुलर गोइटर। ठीक है, बात खत्म। फिर बारी आती है अपने टॉक्सिक एडिनोमा की, ये सबसे आसान है हमको याद रखने में। सो यू विल सी ये आपका थायराइड ग्लैंड हो गया, एंड दिस इज द नोड्यूल दैट इज बीन फॉर्म, दिस इज द नोड्यूल दैट इज बीन फॉर्म। ठीक है, ये नोड्यूल है, ये आपके बाकी के फॉलिकल्स हैं। ठीक है, so when you look at the uptake in rest of the follicles, you will see there's a minimal uptake or a normal uptake that is there. In this area you will see a lot of uptake. So if there is one uptake, in fact sometimes the nodule becomes so active that it won't let anywhere else for the gland to have an active uptake, सिर्फ आपको ऐसे दिखेगा। जब आप गामा कैमरा में आप इसको विजुअलाइज करोगे ना, तो इमेजिन ओनली ऑरेंज ऑरेंज अपटेक, तो यहाँ पे डिफ्यूज सब में दिखेगा, यहाँ पे पैची दिखेगा, यहाँ पे सिर्फ एक साइड पे अपटेक दिखेगा. एंड दिस इज हाउ यू नो ऑन अ रेडियो एक्टिव आयोडीन दैट इट इज गोइंग टू हैव द फॉलोइंग डायग्नोसिस. एंड ऑल दीज अपटेक्स नो, इन सबको क्या बोलते हैं? इनको बोलते हैं हॉट अपटेक, गरम गरम. हॉट का मतलब होता है एक्सेसिव अपटेक. सो ऑल दीज अपटेक्स आर कॉल्ड एज हॉट. तो रेडियो एक्टिव आयोडीन में ना 3 टाइप के अपटेक्स होते हैं, हॉट, कोल्ड एंड वार्म. हॉट का मतलब नॉर्मल से ज्यादा, वार्म का मतलब नॉर्मल के बराबर, कोल्ड का मतलब नॉर्मल से कम. कोल्ड अपटेक और अ कोल्ड नॉडुलर अपटेक इंडिकेट्स मैलिग्नेंसी, मतलब वो डिटरमाइन करे कि वो प्रॉबेबली कैंसर की तरफ है. एज सिंपल एज दैट. ठीक है, तो ये आपका इन्वेस्टिगेशन स्टेटस हो गया इन टर्म्स ऑफ थायरोटॉक्सिकोसिस. मैनेजमेंट इज गोइंग टू बी वेरी वेरी इंपॉर्टेंट. ठीक है, आई होप एवरीबडी इज एबल टू अंडरस्टैंड. नो, मतलब मैं बोल तो रहा हूँ, मुझे रिस्पॉन्स समझ में नहीं आ रहा. ठीक है, बीच में कुछ समझ में नहीं आया ना बेटा, पूछ लेना. मुझे तो लग रहा है कि समझ में आना चाहिए. If you have any questions, any queries, you can ask in between only. बीच में ही पूछ लेना, बट इन जनरल बता रहा हूँ कि आई फील कि आई एम मेकिंग सम सेंस. ठीक है, सो मैनेजमेंट के बारे में बात कर लेते हैं. So when you talk about the management, so we talk about the management of all these toxicoses. So it's going to be a stage-wise management. So what is the first line management? देखो, first line management for all these patients is to start the patient on anti-thyroid drugs. So सब में सर्जरी पहले नहीं करेंगे, सबसे पहले आप anti-thyroid drugs start करोगे. So in all these patients, you will start the patient on anti-thyroid drugs, right? So the first thing we are going to do is going to have an anti-thyroid drugs. Now, I hope everybody knows the list of anti-thyroid drugs that you can give. Now, अगर आपको अपने एग्जामिनर को सुपर इम्प्रेस करना है, तो एंटी-थायरॉयड ड्रग्स कौन कौन से हैं? सो यू से दिस इज द थायरॉयड फॉलिकुलर सेल. ठीक है, then you have, this is the blood circulation, and let's say this is where you have the peripheral conversion that is going to occur, that is going to be the liver. ठीक है, now let's say, and this is sodium iodine symporter. This is sodium iodine symporter which is going to bring these ions. अंदर आपके पास एक एंजाइम मिलेगा, एंजाइम को बोलते हैं थायरोपेरोक्सिडेज, दैट इज TPO. So let's say this is a sodium iodine symporter. So there is a sodium iodine symporter. अंदर एंजाइम मिलेगा थायरोपेरोक्सिडेज. यहाँ से you will see the T3, T4 is secreting into circulation. Peripheral T4 gets converted into T3. यही है. ठीक है. Now anti-thyroid drugs में remember the important ones that are going to be asked in the exam. सोडियम आयोडीन सिम्पोर्टर का जो ब्लॉकर है, इसको आप बोलते हो परक्लोरेट. इट इज परक्लोरेट as well as thiocyanate. So 2 drugs which are going to stop the sodium iodine symporter is perchlorate and as well as thiocyanate. फिर the drug that is going to inhibit the thyroperoxidase enzyme. Now drug that is going to stop, drug that is, see, this has been your repeat, I mean, like whenever they talk about it, there's going to be very important. The one that inhibit the thyroperoxidase enzyme is going to be carbimazole. Drug that inhibit the thyroperoxidase enzyme is carbimazole and propyl thiouracil. And the propyl thiouracil, ठीक है, which was PTO. Clear? Drug that is going to inhibit, drugs that are going to inhibit the peripheral secretion, मतलब ये blood में जाने नहीं दे रहा है, right? One that is going to inhibit the peripheral secretion is going to be sodium iodide, potassium iodide, as well as Lugol's iodine. It is going to be Lugol's iodine, ठीक है? And the last one, drug that inhibit the peripheral conversion. Drug that inhibit the peripheral conversion, सारे P से हैं. Number 1, it is going to be propyl thiouracil. Number 2, a beta blocker, that is propranolol, non-selective. It is propranolol. a steroid that is going to be prednisolone. Right? Propylthiouracil, propranolol, and prednisolone. These are going to be the drugs that inhibit the peripheral conversion. Right? So remember two important things. Safe in pregnancy. Which antithyroid drug is safe in pregnancy? That is going to be propylthiouracil. Which antithyroid gland reduces the vascularity of the gland? Reduces the vascularity of the gland is going to be sodium iodide, potassium iodide, as well as Lugol's iodine. Okay. So obviously in Graves' disease, no, I want these antithyroid drugs to be used. So normally when you give the antithyroid drugs in Graves' disease, it's a combination of propylthiouracil with Lugol's iodine. Okay. So these are your antithyroid drugs, right? So these are the antithyroid drugs that has to be given. And remember, once you start the antithyroid drug, before the surgery, you have to make the patient euthyroid prior to surgery. Make the patient euthyroid prior to surgery. This is the most important prerequisite that you have. Now same is going to be validated for the rest of them. ठीक है? अच्छा, ये आपका first line management हो गया. Now once the patient is euthyroid, the second line management is going to be surgery. It is going to be surgery. So Graves' disease may, the surgery that is currently recommended is going to be total thyroidectomy. This is going to be total thyroidectomy. अगर यहाँ पे unilateral, if it is in multinodular goiter plumbers disease में single side is involved, then it is going to be, for a unilateral condition, it is going to be lobectomy. For a bilateral condition, it is going to be total thyroidectomy. It is going to be total thyroidectomy. Right? Whereas here, when you talk about toxic adenoma, it is usually lobectomy. ठीक है? बड़ा आंसर हो गया ना? तो whenever they ask you thyrotoxicosis, usually it's a 10-mark question. Okay? So thyrotoxicosis, they'll ask you define thyrotoxicosis, give the examples of thyrotoxicosis, explain Graves' disease, explain Plummer's disease, explain toxic adenoma. ये पूरा 10 marks का है. ठीक है? So if you are able to answer this, this is how you're supposed to answer. So start all the way with the basic definition of thyrotoxicosis, causes of thyrotoxicosis, clinical features of thyrotoxicosis, presentation, extrathyroid manifestation, systems involved, investigation, as well as management. Clear है? ठीक है? कोई सवाल, कोई शक? Anything? ठीक है? So we have completed the entire thyroid swelling वाला part. ठीक है? Toxicosis भी हो गया, इसमें goiter भी complete कर लिया. ठीक है? Now another question that you have is about retrosternal goiter. ठीक है? तो let's understand what is this retrosternal goiter. तो retrosternal goiter 5 marks का question है, छोटा सा आंसर होगा, quickly देख लेते हैं. ठीक है? So we'll be talking about the next question, that is going to be your retrosternal goiter. So let's understand retrosternal goiter. Now by definition, what is retrosternal goiter? Now by definition itself, retrosternal goiter is defined as, we call it as retrosternal goiter. RSG is defined as, it is defined as more than 50% of the thyroid gland, is below the neck level. If more than 50% of the thyroid gland is below the neck level, this is what we call it as retrosternal goiter, right? Now, when you talk about the retrosternal goiter, what are the types of the retrosternal goiter? So the second thing that immediately you should resort to is the types of the retrosternal goiter. Now we divide them into two categories, that is a primary retrosternal goiter and a secondary retrosternal goiter. So दो varieties हैं. One we call it as the primary retrosternal goiter. Another one is what we call it as the secondary retrosternal goiter. So we have the primary retrosternal goiter and a secondary retrosternal goiter. Now, what do you mean by a primary retrosternal goiter and what do you mean by a secondary retrosternal goiter? Primary का मतलब क्या होता है, secondary का मतलब क्या होता है? Now, a primary retrosternal goiter, it is a retrosternal goiter. It is a retrosternal goiter arising from ectopic thyroid gland, arising from an ectopic thyroid gland situated in retrosternal space. So an ectopic thyroid gland which is present in the retrosternal space, and from there if the goiter arises, it is called as a primary retrosternal goiter. Secondary is what is more common. You will see that it is a normal cervical thyroid gland enlarging to descend into retrosternal space, to descend into retrosternal space, occupying, or I can say a normal cervical thyroid enlarging to descend into retrosternal space where more than 50% of thyroid swelling, is below the neck level. It is below the neck level, and this is what we call it as a secondary retrosternal goiter. So the definition between a primary and a secondary retrosternal goiters are going to be important. So in a primary retrosternal goiter, these are the two different types, that is the primary and the secondary, that you have to remember. See? Now, the other varieties also in terms of their presentation, it's like one we call it as the plunging goiter and all that. We don't need to worry about it. Just remember the primary and the secondary retrosternal goiters which are present. Now, how does a patient of retrosternal goiter is going to present to you? So, clinical features. So, clinical features associated with retrosternal goiter, right? Now, what are you have to write it? I'm just going to tell you, but just for the sake of understanding, if you take this as a representation of the neck, this is the suprasternal notch, this happens to be sternum, and this continues into xiphisternum, right? When you talk about the retrosternal goiter, we are talking about this is the thyroid gland, and which is going to enlarge and then descend below the sternal space, and more than 50% of the thyroid gland is now going to be present below this. There's more than 50%. There's more than 50% of the thyroid gland is present below the level of neck. It is going to present below the level of neck. Now, what is the presenting findings that you're going to see? Now, usually in a retrosternal goiter, the usual age of presentation is same as any goiter, that is between 30 to 40 years. Again, it is more common in females when compared to male. It is more common in females when compared to males, right? So when they talk about the features, they will present to you as a midline neck swelling. They present as midline neck swelling extending below the neck level. Extending below neck level. That is the first clinical finding that you'll see. So there's a midline neck swelling that is going to extend below the neck level, right? Now this again is usually going to be painless. This is going to be painless, and same as goiter, it is going to be gradually increasing in size. You will see that it is going to be gradually increasing in size, right? It is going to be gradually increasing in size. Clear? Chalo. Now, obviously I would like to examine it. So on examination, the first thing you will see, this is going to move upwards with deglutination. This is going to move upwards with deglutination. This is going to move upwards with deglutination. That is going to happen. Now, as it is going to move upwards with deglutination, what is the other thing that you will see? Remember, even it is moving with upward with deglutination, the lower border of thyroid is not visible. Not only visible, it is not palpable as well. It is not visible. At the same time, it is not palpable as well, right? So it moves upwards with deglutination. The lower border is neither visible nor palpable, right? Now, when you examine it, because the gland is enlarging, it is going to suppress or compress the thoracic inlet also, right? So all these head and neck veins, they drain into your thoracic cavity, so all these are going to get blocked. So there will be presence of distended. There is distended neck and chest veins. There are distended neck and chest veins are going to be present. Now, another very interesting thing, there is something called as Pemberton sign positive. Now, what is this Pemberton sign positive? Now, you ask the patient to raise both the hands above the level of head. Now, as you raise both the hands above the level of head, what is going to happen? You are now further compressing this thoracic inlet. Now, as the thoracic inlet is getting compressed more, obviously, what is going to happen? The veins are going to go occlude more. If the veins are going to get occluded, all the blood that is flowing from the face will not be able to go. It starts pooling in the face. If the blood starts pooling in the face, there will be presence of congestion. So, what is Pemberton sign positive? Is presence of facial congestion. There's presence of facial congestion on elevating both the arms, above the level of head. It is the presence of facial congestion on elevating both the arms above the level of head is what we call it as Pemberton sign positive. And the last clinical feature that you will see. What is the last clinical feature? When you do percussion in thorax, you should have a resonant node. But now because the gland is occupying on the surface wherever the gland is present, it will have dull node. So presence of a dull node on percussion. It is dull node on percussion is found. There is dull node of percussion is formed, that is on it. So on examination, it moves upwards. There's a lower border is neither visible nor palpable, distended in neck and the chest vein, Pemberton sign positive, and there's a dull node that is present. Now, when you talk about what are the investigations that you're supposed to do, in the investigation, I would number 1 get a thyroid function test, number 2 get an ultrasound of the neck done. Next, you should always get a radioactive iodine scan done to know the extent, and obviously to know within the thorax, also get the CCT of neck and thorax. So when you get a CCT of the neck and thorax, you will be able to know the true extent of the thyroid swelling which has gone into the intrathoracic space. So you know the thyroid function test, the ultrasound is done, the radioactive iodine and the CCT is done, right? Now once you have concluded it, the management is going to be surgery, and here it is going to be total thyroidectomy. Remember, whenever you are taking any patient for total thyroidectomy, you remove the entire thyroid gland. So thyroid is going to be giving you a thyroid hormone. But if the gland is gone, how would you complement it? Now for supplementation this, here you have to also mention, whenever you write a total thyroidectomy, write lifelong thyroxine. Now this thyroxine is basically a T4 supplement. So total thyroidectomy with lifelong thyroxine is what is required It is what is required for both. So total thyroidectomy with lifelong thyroxine is going to be the treatment for your retrosternal goitus, right? So this concludes our entire discussion on our thyroid gland, right? So discuss solid thyroid nodule, thyrotoxicosis, goiter as well as retrosternal goiter. ठीक है? Clear? इतना लिखो is more than enough. ठीक है? So far any questions in thyroid bias? Quick feedback. कोई सवाल, कोई शक? Clear है? Can we move on? चलो. So we're talking about the questions which are present in breast. So in the previous exam, what are the questions which are asked in breast? I'll just quickly mark it down. तो breast पे हमसे पूछा हुआ है Andy के बारे में. Write a short note on Andy. We have a question on Phyllodes tumor. We have a question on Fibroadenoma of the breast. The Fibroadenoma of the breast. Andy पे सवाल है, Phyllodes tumor पे है, and the Fibroadenoma of the breast. There are 3 questions that are present. Sir, about the parathyroid gland. So exams on the April 7th, and this is helping a lot. Thanks to the entire team. Great, thank you. I mean, like, it's so satisfying to hear that, you know, the effort that we're putting in is actually making a little bit of difference in your preparation as well. After the thyroidectomy, parathyroid glands are also to be resected. No, beta. Whenever you're doing a thyroidectomy, parathyroid gland should always be preserved. Parathyroid gland तभी निकालोगे जब उसमें डिफेक्ट है. Otherwise, thyroidectomy करते वक्त I will dissect the parathyroid gland away from the thyroid gland and extract the thyroid gland. Parathyroid gland को कभी नहीं निकालना है. In fact, अगर गलती से निकल जाता है, accidental removal of parathyroid gland during a thyroid surgery must be reimplanted on the sternocleidomastoid muscle of the same side. अगर लेफ्ट पैराथायरॉइड निकला है तो लेफ्ट sternocleidomastoid muscle पे रीइम्प्लांट करोगे. ठीक है? सो डोंट फॉरगेट अबाउट इट. नहीं निकालना बेटा, पैराथायरॉइड क्यों निकालोगे? ठीक है. आफ्टर, अच्छा ये we have already answered. What about the parathyroid gland? बेटा पैराथायरॉइड पे ना there is one question on hyperparathyroidism, but that is dealt in medicine. तो सर्जरी में तो मुझे कोई प्रीवियस क्वेश्चन पेपर में पैराथायरॉइड पे कोई सवाल नहीं मिला. ठीक है, चलो. Can we move on to the breast? Quick feedback. I hope everybody is clear on this. Quick feedback. चलें? Can we move on? Can we move on? चलो. So पहला है हमारा Andy पे सवाल है. ठीक है? So we'll talk about what is an Andy. So all these questions that you have, Andy has been your 3 marks question, Phyllodes has been your 5 marks question, Fibroadenoma is a 3 marks question. तो usually breast से आपका छोटा छोटा टॉपिक्स ही आता है. ठीक है? So Andy का हम पहले देख लेते हैं. So the first one, the first answer that we are going to discuss about is going to be Andy. ठीक है? Andy का मतलब क्या? Andy stands for aberration. Andy stands for aberration in normal development. In normal development and involution of breast. It is a normal development and involution of breast. This is the definition or the full form of Andy. So whenever we talk about Andy per se, no, तो Andy के 2 classification है. एक clinical classification of Andy है. Another one is what we call it as the histopathological classification of Andy. So the Andy can be classified into 2 variants. One, we have a clinical classification. Another one is based upon the histopathology, right? So we'll be talking about both. We'll talk about the clinical classification of Andy. We have the clinical classification of the Andy and the histopathology. And we have the histopathology of the Andy. So we have the clinical classification as well as the histopathology of the ANDI that is present. Okay? Achha. So in the clinical classification, what are we going to look at it? So in the clinical classification, the entire ANDI is classified based upon the age of presentation. So you have the age group and the disorders it is going to be associated with. So we have an age-wise disorder that is going to be present. So on one hand, you have the age group, and the other hand, you are going to have disorder. Okay? Now, what are these age groups and disorder? Now, whenever a breast disorder starts, it will only start once a patient has developed a breast. That is going to be thalarche. The normal age of thalarche is going to be 9 to 11 years old. So जो भी disorders होंगे वो 11 के बाद ही होंगे क्योंकि 11 से पहले तो breast है ही नहीं. अगर breast नहीं है तो disorders कहाँ से होंगे? Simple सा concept है. ठीक है? Now, could you please repeat? Okay, हम बात कर रहे हैं ANDI के बारे में. ANDI full form stands for aberration in normal development and involution of breast. Aberration means which is not normal or which is going to be abnormal growth that is going to be present in the breast. I'm going to divide the two classifications of ANDI. One is called as a clinical classification, another one is called as a histopathological classification. Clinical it is divided on the base of age group, and based on that age group we have disorder. As we all know that every single disorder of the breast will only be seen once the breast develops, or the normal age of present development of the breast is what we call as thalarche, that is going to be 9 to 11 years. तो 11 साल से पहले तो breast है ही नहीं. अगर breast नहीं है तो disorder कहाँ से होगा? तो आपको disorder मिलेगा 11 के बाद. ठीक है? That means the usual age of presentation of the first subset that you will see is age group between 15 to 25 years. So age group between 15 to 25 years के बीच में ना you will get disorders like fibroadenoma of the breast. Get the fibroadenoma of the breast. There will be presence of fibrocystic disease of the breast. Fibrocystic disease of the breast. Then you have breast cyst. So usually it is an uncomplicated. Okay? So that is between 15 to 25 years. Second set of age group is going to be 25 to 40 years. Or 25 to 40 years के बीच में you will get disorders like again same as fibrocystic disease. It is going to be the fibrocystic disease of the breast, fibroadenoma of the breast, fibroadenoma of the breast. You have the breast cyst, but there's one disorder which is going to be very important for us to remember. It is going to be the Phyllodes tumor. That's going to be Phyllodes tumor, that is 25 to 40. Now then you have age above 40 years. So in age above 40 years, the conditions that you will see is going to be the fibrocystic disease. It is going to be the fibrocystic disease and condition like duct ectasia. Condition like duct ectasia as well as duct papilloma. So these are disease, the disorder in association with that of its age of presentation that you're going to see. Okay? So if I just simply classify them, this is the first subset that you should know. Right. So this is in respect to that of the ANDI's first classification. Based upon the histopathology, the ANDI is divided into the following components. So you have hyperplastic disorder, that is because of hyperplasia. It is because of the fibrous component. It is because of the fibrous component. It is a cystic form of ANDI. That is papillomatosis. That is a papillary growth factor. And glandular component, that is a adenoma. So based upon the histology, the and is divided into hyperplasia, fibrous, cystic, papillary, as well as adenomatous growth pattern. Okay. So these are the component of Andy. Okay. So this is going to be a short note when it comes on Andy. This is what you have to describe, that Andy has classified the breast disorders into clinical as well as histopathological. Clinically, these are the disorders that are going to be oriented, and on a histopathology, this is what you're supposed to remember. Okay. So the first topic about a short note on Andy is what you have to write. Second is going to be your fibroadenoma and phyllodes tumor. So we'll quickly go through the fibroadenoma and then I'll run to the phyllodes tumor. Okay. So the question number 2 is going to be on fibroadenoma. It is the fibroadenoma of breast. Now when it talks about the fibroadenoma of the breast, so fibroadenoma of the breast itself is saying it consists of two different components. It consists of two different components. That is going to be the fibrous component as well as adeno is glandular component. It is going to be a fibrous as well as a glandular component. So this is basically an example of a mixed tumor. This is going to be an example of a mixed tumor, right? Now, at what age do you see this? The usual age of fibroadenoma, we just learned, it is seen between 15 to 25 years. Now, what is the site of origin? So, what is the site of origin for the fibroadenoma of the breast? Now, for that, a quick recap on how does a breast basically looks at. This is the representation of the breast. You can see that this is the pectoralis fascia. This is the representation of the nipple. And when you look at the TDLE unit, this is going to be your terminal duct. This is going to be the ampulla. This is the major lacticiferous duct. These are the minor or the branch lacticiferous duct. This is going to be the lobule of the breast. This is going to be the lobule of the breast. Within the lobules, you have the glandular component, that is the alveoli of the breast. So the alveoli are present within the breast tissue, right? Now, a quick labeling so that you have the sound sense of it. This last portion is what we call it as the terminal duct. This is what we call it as the ampulla of the breast. This is what we call it as the major lacticiferous duct. This is what we call it as the major lacticiferous duct. These are what we call it as the minor, or also called as the branched lacticiferous duct. Minor or the branched lacticiferous duct. This is what we call it as the lobule of the breast. This is what we call it as the alveoli of the breast. And all these put together is what we call it as the lobe of the breast. It is what we call as the lobe of the breast, right? Right. Now, when you look at the fibroadenoma, it has two things. It has got the fibrous capsule, and because it is going to arise from the gland, it is going to have a glandular tumor, right? So the word fibro means fibrous, adeno means glandular, oma means tumor. So word fibro means it has got a fibrous component. Adeno means, the word adeno means glandular component, and the word oma stands for tumor. So this is going to be a benign tumor which is going to be involving the fibrous and the glandular component. Hence, it is called as a mixed tumor. Okay. Now, when you talk about the origin, it is going to origin. So you'll see the fibroadenoma of the breast. It is going to arise from the lobule of the breast, right? So the fibroadenoma is going to arise. So just I'm going to tell you, this is where the fibroadenoma of the breast is going to be present. This is where you will see there will be fibroadenoma of the breast, right? So the fibroadenoma of the breast is going to arise from the lobules of the breast. This is going to arise from the lobules of the breast, right? Now, how would this present to you as a clinical feature? So, what are the clinical features? The clinical features of a breast lump. The clinical features of a breast lump. Number one, you will see this is going to patient is going to present to you as lump in breast. Now, this lump in breast, it is going to be incidentally found. So, it's an incidentally found breast. So, this is incidentally found. This remains painless. This remains painless. It is going to be gradually increasing in size. This is going to be gradually increasing in size. So normally when you say size, it is usually 2 to 3 centimeters. You do not have fibroadenoma more than 3, right? Okay. So it is going to be 2 to 3 centimeters. This lump in the breast, it is going to present as a painless lump and it is going to gradually increase in size, nothing more than that. You would like to examine it. So on examination, what are the findings that you will see in the fibroadenoma of the breast? First one, you will say it is going to have a smooth surface. Second, when you palpate it, it feels like a tip of the nose, that it is going to be firm in consistency. This is going to be firm in consistency. And last, it is going to be hypermobile. Now, why call it as hypermobile? Because in order to palpate it, you want to fix the swelling. Now, every time you try to fix the swelling, it slips away. Now, as it slips away, it is called as hypermobile. And because it is hypermobile, this is also referred to as the breast mouse. This is given a nickname, and the nickname of this is what we call it as breast mouse, right? Now, how would you like to evaluate it? Now, in terms of investigation for fibroadenoma, for any breast lump, remember the investigation for any breast lump should follow a protocol, that is what we call it as the triple assessment. So in the triple assessment, what are we trying to do? So in the triple assessment, number one is going to be clinical examination. Number two, it is going to be your radiological assessment. Now, according to the radiological assessment, here I would like to do an ultrasound, right? Remember, any female age less than 40 years, ultrasound becomes the first investigation. More than 40 years, it is going to be mammography, right? Third investigation, or the third in triple assessment, is going to be the cytology. So in cytology, I would like to do an FNSE of the lesion, right? So when you do an ultrasound and you do an FNSE, now we have a confirmation that it is the fibroadenoma of the breast. Now remember, on an ultrasound, if the size of the fibroadenoma is more than 5 centimeters, this is what we call it as the giant fibroadenoma. This is what we call it as a giant fibroadenoma, right? Now, once you've diagnosed it as the fibroadenoma of the breast, what is the current management? Now, the current management, please do not write directly as surgery. You will say based upon the size, right? So, the management of the fibroadenoma of the breast, depends upon if it is less than 5 centimeters in size, or is it more than 5 centimeters in size. If it is less than 5 centimeters in size, we will see whether on FNSE, if there is any atypia, that is any atypical finding on FNSE, no atypia, there is presence of atypia. If there is no atypia less than 5 centimeters, then you can go ahead with observation. More than 5 centimeters presence of atypia, you have to go with surgery, and the surgery here is going to be enucleation. Now, what is an enucleation is, you open the capsule, you remove the tumor, you close the capsule, right? Remember, fibroadenoma is an encapsulated. So I can say fibroadenoma is an encapsulated lesion. If it is more than 5 centimeters, directly take the patient for enucleation, right? So size more than 5 centimeters, I'm directly going to take the patient for enucleation. Less than 5 centimeters, no atypia, observation. Less than 5 centimeters with atypia, do with surgery, that is going to be enucleation. That is how you're going to manage for fibroadenoma of the breast, right? So there's a short note on the fibroadenoma, and all these points that we have discussed is what you have to write. So far, any doubts, any questions, quick feedback? किसी को कोई सवाल, कोई शक, कोई कुछ पूछना चाहता है? Quick feedback. Clear? Can you move on? Okay, chalo, great. So the last topic that is going to be associated with breast is going to be phyllodes tumor. So talk about the answer associated with the phyllodes tumor. Now, phyllodes tumor was initially known as cystosarcoma phyllodes. It's also called as the cystosarcoma phyllodes, or also called as the serocystic disease of Brodie's. Also defined as the serocystic disease of Brodie's. So either you call it as a phyllodes tumor, or you call it as the serocystic disease of the Brodie's, or the cystosarcoma phyllodes. Everything is basically the same. Now, what is there to understand is phyllodes is predominantly a benign tumor, right? Now, because it is predominantly a benign tumor, giving it a malignant name is not justifiable. So hence the word sarcoma is not dropped. Okay, so now we don't use the word sarcoma. Now it is an old one. Atypia is a histopathological finding where you have atypical cells. They are not normal, but they are not malignant as well. There's some deformity or destructure that is present, but does not have any significance per se. And that is what we call as atypia. Few atypias point towards malignancies, and few of them point towards benign nature. So whenever you have atypia, that means you're doubtful. It is not normal, right? And that atypia always warrant any precaution, and that precaution is going to be surgery only. Okay? So in phyllodes tumor, it is going to be a cystosarcoma phyllodes. It is dropped the word sarcoma. Now it is also called as the serocystic disease of Brodie's per se, right? Now, so how does the patient of phyllodes tumor is going to present to you? Now, when you talk about phyllodes tumor in terms of characteristic feature, so we talk about the characteristic features of the phyllodes tumor. Number one, it is a mixed tumor. That means it has got two different elements. Now, what are these made up of? It is made up of both epithelial as well as mesenchymal tissue. So it is going to be consistent of both epithelial as well as mesenchymal tissue. So hence is an example of mixed tumor. It is a rapidly increasing tumor. It is a rapidly increasing in size, right? This usually rapidly increases in size. It's an example of a mixed tumor. It is rapidly increasing in size, and it is going to take its origin. It is going to be involving from the duct as well as lobe. So it is going to have a mixed origin as well. Okay. Now, how does a patient of phyllodes tumor present to us? The clinical presentation. So we'll talk about the clinical features. So we'll talk about the clinical features. The first one is the age of presentation. We just learned the age of presentation of phyllodes tumor is going to be between 25 to 40 years. It is going to be 25 to 40 years. Now, age in breast disorders is very, very important. Now, how the patient present to you? The typical presentation, the patient will present to you as lump in breast. Now, this lump in breast is going to be rapidly increasing in size. This is going to be rapidly increasing This is going to be rapidly increasing in size. It remains painless. It remains painless. So lump in breast, rapidly increasing size and remains painless is the initial presentation that you will see in the phyllodes tumor. But I would like to examine it. So on examination, now this is where important findings will be there. So on examination, what do you find? So on examination, you will notice in the phyllodes tumor, usually the nipple is deviated away from the lump. Here nipple is deviated. It is deviated away from lump. It is deviated away from the lump. It is going to have a nodular, because it is going to have multiple cysts are going to develop. And what happens in the phyllodes tumor? No, the small fibroadenoma like lesions, no, they obstruct the gland, the duct itself, causing an accumulation of fluid also. So it is going to have both solid and the cystic component. Now because it is solid and cystic component, it is going to have variable consistency. Because it has got both solid and cystic component. It has got both solid as well as cystic component. So nipple is deviated away from the lump. It has got variable consistency. Nodular surface is what we call as bossulated surface. Now what is a bossulated surface is? In a bossulated surface you will notice. So normally this is how the breast contour would look like, and this is the nipple. In a bossulated surface, you will see the breast surface is going to become like this. The multiple nodules are formed, and that multinodular status is what we call as bossulated surface. So you have the nipple deviated away from the lump. It has got variable consistency. It is going to have a bossulated surface. It is going to have a bossulated surface. Now, as it enlarges more, it is going to compress the veins on the skin as well. So you will be presented with superficial dilated veins. There will be the presence of superficial dilated veins. Now, as it continues to enlarge, as the gland, because it is going to be the tumor or the lesion is going to enlarge rapidly, now it is going to exert pressure on the skin, and that is going to result in ulceration. So there will be presence of skin ulceration. The presence of skin ulceration. Now this skin ulceration, the skin ulceration is secondary to pressure induced necrosis. It will be secondary to pressure induced necrosis. So these are the examination findings that you have on a phyllodes tumor. Now how would you like to investigate? So the investigation that we are going to follow on a phyllodes tumor. The investigation is in the same sense of protocol that we have followed the triple assessment. The first one is going to be the clinical examination, which we have already discussed all the findings of. Now along with the clinical examination, now I have to do a radiology. Now in the radiograph, I would like to do an ultrasound because the age is less than 40 years. Now after radiology, then we will go ahead with cytology. Now cytology, here it is going to be true cut biopsy. So when you do a true cut biopsy on a histopathology, on the histopathology, you will see presence of leaf-like arrangement. There is this leaf-like arrangement of tumor cells. There is this leaf-like arrangement of tumor cells. Now, because there is leaf-like arrangement of tumor cells, the name phyllodes, the word phylloid is leaf, is arise from this, that is leaf-like arrangement of the tumor cells, and that is what you see in true cut biopsy. Now, how would you like to manage? So, what is the management? The management of the phyllodes tumor purely depends upon the histopathological finding, that is on the HP result. So what you do is, it depends on a HP, we'll see the mitosis count, right? So the management depends upon whether it is benign, borderline, or it is malignant. So based upon the HP, I'm going to look at the mitosis. So when you look at the mitosis count, I can differentiate them into the following varieties. When you look at the mitosis counts, you'll have less than 4 mitosis for 10 high power field. Then you have between 4 to 9 mitosis for 10 high power field. And the last one is going to be more than or equal to 10 mitosis for high power field. Now why this is important is, if you have a mitosis which is less than 4, it is benign. If it is between 4 to 9, it is borderline. If it is more than 10, then it is a malignant phyllodes. That is a malignant phyllodes. Now, if it is a benign or a borderline phyllodes, here we will do a wide local excision. Here we do a wide local excision with 2 centimeter margin. With 2 centimeter margin. If it is a malignant one, remember when you're doing a breast conservative surgery, the margin is 1 centimeter, but phylloids, the margin safely is put to be as 2 centimeters. Now, if it is a malignant phylloids, you will go ahead and perform simple mastectomy. You'll do a simple mastectomy, and remember here, lymph nodes or lymph node dissection is not done. Lymph node dissection is not done due to so lymph node dissection is not done. Why it is not done is because usually in phyllodes tumor lymph nodes are spared. So reason why it is not done, in phyllodes tumor, lymph nodes are usually spared. Because the lymph nodes are usually spared, right? So hence we are not going to do a radical or a modified radical mastectomy. We'll stick to simple mastectomy, right? So this is with respect to phyllodes tumor, right? So these are all your important questions that is asked in your exam. So we covered anti-phylloids as well as fibroadenoma of the breast. So for any questions, quick feedback, कोई सवाल, कोई शक, कुछ पूछना है? Quick feedback. Any questions? Anything that you would want to ask? Right, so if you have no questions, so that's it for today, guys. Tomorrow we'll resume back again another session of Farre. Tomorrow we'll be taking about the next part of it. We'll start with the GIT part also. So we'll touch upon all the important answers. And if time permits, I'll take about few other questions also which you can ask or you can put across. Thank you so much for joining. If you have any questions, any queries, do write out or reach out to me. You can also see in our Telegram group as well, but I do also have my own personal Instagram and Telegram. It is by the name as the surgery guy. So if you have any questions or queries, you can follow this on the Instagram. This is by my own name, that is Dr. Sandeep Seeram Reddy. So any questions, any queries, feel free to reach out. Right. Thank you so much for joining. See you guys tomorrow. Bye.